What if spine surgery isn't the real breakthrough, but that is a backup plan? Today, we're sitting with Dr. Jeff Gross, a spine fellowship trained neurosurgeon known for pushing medicine beyond the scalpel into stem cells, exosomes, peptides, and some non-surgical spine care. Welcome to the show, Dr. Jeff.
Thank you, and thanks for that great intro. Is it okay that I borrow it and use it elsewhere? That's fantastic.
You don't even have to borrow it. It's yours.
I'm changing my business card. Let's do it.
Yeah. There you go. Oh, that's great. Well, I'll tell you what, this is going to be fantastic because both Dr. Terry and I, we see patients all the time for the last 35 to 40 years that talk about getting surgery. And now with this new frontier, we're looking forward to having this conversation. So let me start out with asking you, you trained in one of the most scalpel forward specialties there is. And, what was that moment, a patient, a complication, a recovery you watched where you thought, man, there's got to be a better way?
I think that was there, brewing all along, iteratively growing with each frustrating moment of going to these annual neurosurgery and spine conferences, seeing my colleagues. Some are friends, some are idiots. And who knows, I might have been one of those at one point, and hopefully am not too much now. And sadly, the Venn diagram overlaps. But, what I saw was people presenting research. Okay, let's look at a series of 50 spine fusions or something. And that research was presented 40 years ago. So things weren't changing. Meanwhile, professional athletes are going to Europe 20 years ago to get stem cells. And I just didn't feel, I was sort of the non-surgical surgeon. I would show up in the hospital, which I really don't like hospitals. That's where all the sick people are. But I would show up and my colleagues would say, oh, we haven't seen you in forever. And that's because I was only doing surgery if we absolutely have to. We looked back at my numbers a few years back, and it was something like 5% of the patients I saw got surgery. We were just trying everything else first. I was in a spine clinic. We had a chiropractor as one of the offerings in our clinic, other things too. And we would try everything. Surgery was the last option unless there was some kind of emergency, spinal cord involvement, something. So I was sort of the non-surgical surgeon. And when you go through surgical training, they tell you, okay, during your residency, you'll learn how to do surgery. Yeah. And then when you're done, you learn how not to do it. And I just really took that to heart and worked hard at it. Meanwhile, my surgeon friends are patting themselves on the back. Oh, I did 350 surgeries this year. I patted myself on the back when I did less than 50. So that's kind of how it went.
You are a rare breed, but a growing breed from what we see. And I find that really fantastic because we always warn, patients about surgery. We've even had neurosurgical nurses. Yeah. we always wondered why the nurses would end up going to the chiropractor, and they said, man, if patients knew what went on during that low back surgery or how intense it was, you wouldn't do it.
Yeah. It's still quite barbaric in certain ways. Don't get me wrong. There are cases, fractures, massive situations where you still need
right.
To have these open surgeries, these hardware placements. It still exists, but it's overdone. And what happened in this watered down healthcare, sick care system, institutionalized, driven by payers, you get 5 minutes with a surgeon, he throws up an MRI, doesn't even touch you, and he's treating the MRI, not the patient. And sometimes what we see on MRI has nothing to do with the pain. So,
love that.
So the art of medicine is lost in that interaction, and it's just transactional. So,
Doc, I gotta ask you, if you sit down and you go to like this black tie affair, and somebody hears you're a neurosurgeon, and they're like, "Ooh, I gotta talk to this guy about this," and we think of surgeons as repair shops, and you're actually more like a mechanic. And how does that conversation go when they hear you're a neurosurgeon? But then, what's your simplest North Star line that you give them back that kind of educates them and tells you the direction you go?
Well, I tell them a lot what I just explained to you folks, and I say I'm a recovering neurosurgeon, and I think a good neurosurgeon knows how to help patients avoid surgery. In fact, I used to tell patients, and it's still true today, no one knows better than your neurosurgeon how to avoid spine surgery. Like, I really know how to, because I've been in there, I've touched the muscles, I've touched the facet joints. I have an internal understanding. This goes for the radiologist too. Patients come in and say, oh, I looked at my MRI report and I have a disc, herniation or something. And I'd say, well, the radiologist got this a little bit wrong. They missed one up here. But he's a radiologist who looks at those all day. I said, yes, but the last time he was inside of a spine was in medical school cadaver lab. So surgeons really have an understanding of the anatomy and the pathology. So we should know best how to avoid that surgery. And we have to start early, and prevention and so many things go into that. And I've really sort of upped my game on that now about 8 years ago, when I tiptoed and then jumped both feet fully into the regenerative medicine, cellular biology side of medicine.
You mentioned a little while ago that athletes were going to Europe for stem cells 20 years ago. And yet a lot of people still to this day think of stem cells for your shoulder, for your knee, or maybe a hip or something. They're not really thinking about it for the back. And can you listen? And you're known as the cell whisperer. It's the stem cell whisperer. So let's whisper and then start shouting. Educate us about stem cells for the back and how everything works.
Well, listen, there's great research literature / medical evidence publications out of Europe and Asia for a few decades. We are late to the party here in the US, but they have applications for joints. So not just, knees and shoulders and thumbs and ankles, but facet joints, and in some cases, disc. And we have growing opportunities to help people with disc issues. And a lot of that we learn from the peripheral joints, because knees, for example, are the low-hanging fruit. They're very commonly an issue. They have a flat interactive surface, so you get a lot more coverage when you do something, as opposed to a ball and socket joint, a shoulder or a hip or an elbow, which take longer to benefit. And we do those too. But facet joints are incredibly amenable to regenerative options. And we have, again, some things we can do for disc degeneration that have come out of this research. So what we do is we don't make anything up. It's based on good science somewhere, just probably not from the US.
Good.
So who are good candidates? Sorry about that. Can you elaborate a little bit more on, we hear umbilical cord stem cells, blood stem cells, fat cells. Can you elaborate a little more on what works well with spines? Yeah.
Well, so spines is where you put them, and we'll get a little more granular with that in a moment, I guess. But the different biologics are what you put in. So so we try to pair the best of both worlds. So what you can put in is a spectrum of things, all the way from PRP, platelet-rich plasma coming from your own blood, or your own fat can be spun into some stem cells, or your own bone marrow can be made into stem cells. But I prefer the younger donated sources. This is super ethical. It's handled here in the US from accredited tissue donor services. Same place you get a liver or a cornea. And these are from non-COVID vaccinated mothers who are having a C-section baby. Congratulations, here's your baby. Hey, you're kind of done with the umbilical cord, placenta, amniotic fluid. We were going to throw it away. Can we have it? And that's kind of how that goes.
Oh, that's awesome.
Those go to accredited, registered, FDA-registered, certified labs who handle the tissues and the cleanliness, guidelines, CGMP guidelines. These are places that are audited by the FDA. They come and do site visits, and they have documentation, testing, They get quarantined for 2 weeks to make sure there's nothing growing or infected. They do viral testing, every possible viral you can think of, even West Nile virus. And they only make available the biologics, stem cell signaling, which are exosomes, growth factors, what we call secretome, and other components that we can use for these regenerative approaches to things. We're re-stimulating the old inflamed body that's just not able to heal itself anymore like it used to, and we're reminding it how to do that.
Why was there such an issue with umbilical stem cells? Years ago, there was a big controversy of you would have to go out of the country to get umbilical.
I don't think I think that was some mythology, and there are all these clinics popping up in Tijuana and Mexico and Central America, and they love to advertise that it's illegal in the U.S. or it's unethical. They come from aborted fetuses. I mean, this was all mythology that Big Pharma probably had their hand in to suppress us from seeking these natural, non-pharmaceutical, non-surgery approaches.
So that was all going on back then, even more now than ever before. So that's good to hear.
We're more aware and open to the concept of it now. I think it's always been.
Yeah. Could you explain, the average listener is not as aware of where exosomes comes from and from the stem cell. Could you explain a little bit about that and when you would use a peptide versus a stem cell?
Yeah. So this is my day-to-day practice, and I see patients, and we talk peptides and biologics and all kinds of things, lifestyle, all kinds of things. So the peptides are small protein molecules, but some of them have therapeutic benefits. And this is growing, and it's really under the heading of cell signaling. Like we're trying to encourage and nudge our cells into behaving more youthfully, more restoratively. That's the hack of regenerative medicine. That's how it works. Tapping back into the womb and the incredible, protected environment of, healthy cell baby making machinery. And just like we made our knee, you made the cartilage in your knee. Well, that same factory is there, it's just off. And regenerative medicine can turn it back on. Peptides can be used to also encourage those cells. So all cells signal their neighbors. It's like a neighborhood watch. They tell them, hey, we're under attack, get ready. Or they tell them, hey, we're all going to help restore this joint, help us out. And they do that by communicating with their neighbors in two ways. One is with the small proteins, peptides, growth factors. And the other way is through these small vesicles, extracellular vesicles, which we call exosomes. Cells make exosomes, plants make exosomes, probiotics in our gut make exosomes. And there's this sort of symphony of communication going on. We are just now beginning to understand that communication, to nudge our cells into doing what we want them to do.
Dr. Terry, don't you find it interesting that that they make sure that stem cells come from the fetus of a non-vaccinated, COVID vaccinated mother? I mean, yes. If you would have said that a couple of years ago, I think that might have been very challenging as to why.
Well, in California, it would have been illegal.
Yeah. Oh, God. Yeah.
It would have been illegal in a couple of states, but you're absolutely right.
Not Florida.
Shut up.
Oh, that's great.
I'm just going to shut up right now.
Yeah. Oh, anyway. So can you just go over like who would be a candidate for what? Like at what point? Because over the years, we see a variety of different levels of low back pain that sometimes don't respond to even conservative management. When they come to your office, do you have a hierarchy of trauma or injury that you see that goes, okay, this one would be good for peptides, or is that just where you start and then you go exosomes or?
Well, I think we say, everyone's different, right? We start with, let's talk about your lifestyle. How's your sleep, your exercise, your diet, your nutrition, etc. Wow. Because we don't want to offer people regenerative biologics, exosomes, or peptides if the environment's not yet ready. Are there other cellular pathways we have to work on? Maybe we do some lab tests. Maybe we need some imaging, and we do imaging at the highest level. So we're talking about MRIs 3 Tesla or better, with some additional ordering off the secret menu to get some sequences that bring we want to look for the inflammatory changes in the bone edge. So subchondral bone edema, or what in the spine we call Modic changes, are named for Michael Modic, who was a radiologist. And this is really the target, because if you have inflammation in your bone edges, the cells that produce cartilage, which live in the bone, can't work. They can't do it. They can no longer produce cartilage and generate the maintenance of the cartilage or the lubrication of the cartilage. So just like your hair is a protein that's made in the scalp from a follicle, your cartilage in the joint space is made from a chondrocyte cell in your bone. And this was well demonstrated by the French over 20 years ago. And they have 15-year follow-up studies showing why that's where you have to treat this if you're going to move the needle. So I probably went a bit off outside. I colored outside the lines of your question, but I think that is important. Yeah.
When a patient comes to you or is referred over to you, and they go, well, I got MRIs, I got X-ray, I got CAT scan, the whole 9 yards.
Yeah. How
often will you reorder one with maybe contrast to determine, with gadolinium, whether it's scar tissue or healthy tissue?
We rarely, in my spine practice for decades, I've rarely ordered contrast. Some doctors think you got to get contrast to compare scar tissue to non-scar tissue. I think contrast is a heavy metal, gadolinium, and it's not non-toxic. So we use it sparingly. I use it to look for infection or cancer. I rarely look at it for scar tissue. I think that's a bit overkill.
Wow, that's great.
How long do you think you're still seeing surgeons, and there's you have a 5-6 millimeter disc, and they're still doing laminectomies and cages, and they're doing that? And in my opinion, that's 20 years old.
It's 100 years old.
Yeah. So how do you see this information getting out that people are like, they go to the surgeon, he's like, you have a 6 millimeter bulge, and I'll schedule you for surgery in 3 weeks. And the person's going, well, you hardly even touched me, and how do you know? And then but the surgeon's a god, and then they come back, and then 6 months later they can't even move. So how do we get the word out that there are other things and they have to trust?
Yeah, I mean, what we're doing now surgically goes back to the 1940s. So it's, 85 years old, more accurately. Putting a bone spacer where a disc was, doing a fusion. Hardware is a little newer, metallic hardware. Yeah. And the goal of metallic hardware is to stabilize the fusion so it heals faster, so you can get out of the hospital the next day. These haven't changed in 85 years. Yeah, there's a new widget, a new incision, maybe a little smaller approach. It's the same thing, right? Neurosurgeons do 2 things mainly. Spine neurosurgeons. We decompress and make more room in the spine, and or fuse the spine. That's it. Those are the 2 things we do.
And what's your thoughts on the artificial disc?
Oh, I was going to ask him that.
You're making. I like the artificial disc in the right setting, especially the cervical one. It's been great in the right hands. It's better than a fusion, but you're still doing one of these surgeries with a slight modification, right? It's an advancement. And when you have a complete loss of disc function and pain related to that, then it's an option. It's an option.
An option, and yet I understand that sometimes because of how rigid and use of those disc replacements, they're using a metal, which is great. But yet, then as you get older, the adjacent bone starts to deteriorate. Is that something you might see?
Not so much with the artificial disc, but definitely with the fusion. It puts more stress above and below. Absolutely, we know that. Yeah. The second generation artificial disc devices have a little bit of metal and then some, acrylic or non-metal mechanisms. So there's a lot more. They're less clunky and less stressful, I think. Yeah.
Interesting. I think what we typically would see in the office is, they do a trial of conservative management. They come in from maybe a round of, cortisone or, facet block or an epidural or something like that. And it makes it harder for us because now they're coming off of the medications and yet they're in more pain. And at that point, how would you manage that type of patient that's had that, quite a bit of medical intervention? I mean, what would be the first thing that you do when they come into your office?
Yeah, we would break it down. I would get the records from the pain specialist who did the injections to see exactly where they injected. Was it a shotgun blast just to quell pain, or was it strategic and precise, like the right L4-5 facet joint, to see if that was a pain generator? And what's the result? Did the patient feel amazing in that spot for a few days or maybe longer? And if they did, okay, that L4-5 joint is a pain generator, then we need to focus on that. And then we have options for it. So I think the diagnostic element of some of these injections is important to isolate the pain generator, whether or not we're going to do surgery or try something in the regenerative line of things. And I think the more we know about where the pain's coming from, the better we can help the patient, because not all pain is discogenic, not all pain is facetogenic. And of course, we have multifactorial pains. Then on top of that, myoligamentous and central mediated pains, and then amplified pains and coming off medication, rebound pains. I mean, it's complex, right? It's an art that you guys have to be attuned to. I have to be attuned to. And sadly, so many are not.
On the same guidelines that Spencer just said, sorry about that, Spencer, you getting patients coming in and they go, I can't get out of pain, and so I had an ablation.
Yeah.
And my first question to him, did he ask and research where that pain was coming from, or did he just zero in and ablate the nerve so you don't feel it anymore? And they never had the answer to that question. How do you handle when somebody comes into you and says, I have either they've had the ablation or their doctor wants to have an ablation, and what are some alternatives to that?
I say, let's look at the evidence. So did they do the right blocks to confirm that you would be a candidate for an ablation? Ablations can be useful for certain, confirmed facetogenic pain. So confirmed, you can't just ablate things. Now, some pain specialists come at this, I have a patient in pain, I just got to take them out of pain. We're just going to kill everything. That's a shotgun blast. I don't like that. It's not precise. And some patients need ablations at multiple levels from, chronic, diffuse facetogenic degeneration and pain. But we have to sort that out very diligently. And then ablations can be useful, sometimes 6 months or more at a time. The nerves do grow back and the pain does come back. However, we have now been doing some regenerative facet procedures where maybe you don't need the ablations anymore. Ablations have a downside, as I'm sure you know. You denervate, take the nerve supply away to the joint, so it's kind of numb, feels better. But you're also taking the same nerve, supplies the paraspinal muscles, and you start to lose bulk and you lose muscle, and then your posterior chain goes, and then you have debilitation and other problems, and disc degeneration accelerates, and there's a cascade of events that we'd like to avoid if possible.
Do you know how many patients that I'm sending this program to afterwards? Because this is like everything that I've always wanted to hear from another person who's obviously experienced and way more in this.
We were
stuff.
meant to meet.
Yeah, very.
Yes, we were.
I agree. Now, I kind of know the answer to this question, but I want to hear your thoughts. You started to allude to the fact that do you believe that the art of the physical examination is lost, and then a doctor will go, "Oh, you have pain here, right here. Okay, let's do an MRI," and they become so dependent on MRI.
Oh yeah, overly dependent. And I do agree. The exam art and detailed and thoroughness is lost. And it's something else that parallels this. I'll mention because I think you'll find it interesting. When we research literature, when you search PubMed, you say, "Hey, I want to look up this topic." The research goes back. All this has been scanned in and digitized, by NIH or whoever maintains it. Goes back to a certain year. Do you know that year?
No.
1965. So
No.
so much of our observational pattern recognition of the physical exam and symptom description comes from before that, before we had CAT scans. And, CAT scans came around in the late 60s. So before we had, we'll call it, really good axial imaging, everything was about the exam and listen to the patient. And, the real great descriptions of those things are in the older books and older articles. Yeah. So we've lost that. And I really wish, someone would digitize those and put them in an amazing AI that could, you could tap into and say, my patient has these odd symptoms. And they say, "Oh yeah, we know what that is." Boom. It would really help because patients present with symptoms, right? They don't present with just an MRI finding. And if you're just looking at the MRI finding, then it's not clinically correlated. So I'm with you.
Yeah, we tend to comment on how like the seasoned doctor, the one that used to make the house calls, the one that's been around forever, that almost doesn't exist. Well, it's starting to come back, but which they call boutique medicine, but the one that's seasoned has experience and intuition that the younger doctors don't quite have yet. Nothing bad about it, but I mean, on the flip side, some of the interns that we receive are learning new, fresh ideas, or some of the nomenclature changes over the years, and I'm still using like old terminology. So I mean, so they're good for certain experiences as well. But there's something to be said about that physical exam being just to be thorough and 100%. Ask the right questions. Yeah,
100%.
So what would be the most misunderstood diagnosis that you might see walking into your clinic or office?
Well, I'm coming off the spine here. I do, now that I'm in the regenerative medicine side of things, I see more peripheral joint problems than I do spine issues. For example, knees. Knees are very, very common. We treat a lot of knees. And people come in here with, "I've got knee pain. My doctor says I have a meniscal tear. They've done surgery. It didn't get better." And I'm looking at them. I'm examining them. I'm looking at their MRIs. And it's a patellar or patellofemoral syndrome. It's a kneecap problem. They're stiff after sitting. They have trouble walking up and down stairs. And it's just missed by the orthopedic docs who have trained to do knees. So again, they're just looking at the MRI. Sometimes meniscal tears don't hurt, just like small disc protrusions don't have to hurt. Yeah. Right? It could just be an incidental finding on the MRI, and we can't just rely on that. So a lot of misdiagnoses. In my career going back, I'll add sacroiliitis, sacroiliac joint pain. People come in, I have back pain. I ended up having a surgery. It didn't help. Turns out, I said, "Where's your back pain?" "Oh, it's over here on my left side." "Did you show your surgeon that?" "No, I just said I had back pain." And it's sacroiliac joint. All they needed was maybe a single injection in the joint just to calm it down and do some exercises to build up the joint and get their pelvis loose and all kinds of things. So it's, again, disgusting. That's what's going on out there in the world. And the problem is, the Kool-Aid is you have 5 minutes with a patient. to get your $60, and the money is sucked out of the system. So private health insurance and Affordable Care Act have ruined medicine. It was expensive already, but they have ruined it.
Oh, I totally agree.
There was a wonderful article, and I'll be happy to send it to you. It was just an article for the layperson as to why do we still do knee surgery for an ACL tear when physical therapy, when a good solid round of physical therapy will help considerably and not need surgery. And the answer was because insurance still covers ACL tears. And so it'll, until the payers start to wise up, well, you'll still see these unnecessary surgeries.
We've seen a little inkling of that in the last year or two, in that platelet-rich plasma, which is sort of the lowest level of regenerative medicine, where they take your own blood, spin it down, pull out the plasma with the platelet layer, and re-inject it into your tennis elbow or tendonitis somewhere to get this sort of amplified healing response. We've seen insurance companies start to pay for that, even though it's not yet approved for marketing claims by the FDA. So they figured out that it's cheaper in that year than the surgery. But I had a patient come in yesterday, scheduled for knee surgery. I said, I think I might be able to help you. Let's try a regenerative injection. She's like, well, I'm scheduled. It's already approved. Okay. I'm just giving you the option.
Hey, Jeff, don't you think what Spencer just brought up was just really interesting? Don't you think with Lindsey Vonn tearing her ACL and meniscus, and then 8 days later, she's going to compete in the Olympic downhill, don't you think that's going to start shedding some light on we don't need ACL for certain things? We may need it if you're a soccer player and twisting and torquing maybe, but do you think this incident, since it's so highly publicized, do you think that's going to kind of open up some eyes?
It will help. And the type of things that we're doing in the regenerative and peptide space are becoming an area of focus that you can find if you have an appetite for it. I mean, I have people walk in my office that have never heard of peptides. And obviously the algorithm is working because that's all I see on social media. It's feeding me that. It gives you what you want to see, I guess. But, we have so many ways to help your body accelerate its own healing potential. And athletes are doing this. I mean, we just got to pay attention to pro athletes and, other people who, look up what are the options, what are the non-surgical options, first. Yeah, there's a role for ACL repair, of course, but, not everyone. And we have some examples of ACL tears. If you get them acutely with some of the regenerative approaches, we've been able to have some incredible results. Not with everybody, I'm not allowed to make any marketing claims that we can cure or treat a disease or condition with peptides or regenerative medicine, but physicians can't with so many things that are done every day. Even epidural injections aren't approved for marketing claims, but thousands of them are done every day.
Yeah. I want to go back to basics just for a minute for the listeners, just to clarify. We hear so much about stem cells. We're hearing more about exosomes, but I'm not sure if people really understand when you would use an exosome or when you would use a stem cell, if it's two different things. Well, go ahead. I'll let you explain it.
And I want to piggyback on that. We hear stem cells, like we talked earlier, from umbilical, and then some people are, the doctors drawing it from their fat cell and then spinning it down and inject it. Can you even piggyback on that?
Yeah.
The difference.
Again, you can use your own stem cells. You can use donated youthful stem cells. I'm 60. I don't want to use my old stem cells. If they would have fixed the problem already, they would have done it on their own. And when you're 12 years old and you tear something in sports, you heal. Why? Because your stem cell activity is so robust. And when you're 60, you don't necessarily heal that fast or at all. That's when you want the youthful signal. So and it's also a lot easier and efficient just to use donated, parts. So there are many different types of stem cells. There are embryonic stem cells that have a lot more power, and we're not tapping into those yet for my clinical purposes, they are being used in research in different ways. Those are called induced pluripotent stem cells. Most stem cells are called, mesenchymal, MSCs, and they come from the umbilical cord. Some people call these medicinal signaling cells because that's what they're doing. And you can get them from your fat, you can get them from your bone marrow, you can get them from the umbilical cord, you can get them from different sources. And that is the mainstay of what's out there in the community. Well, it turns out that those cells aren't doing the work. They're delivering the message. The message is those growth factors, those exosomes. So you can cut out the delivery and go right to the exosomes. And we like that because they're more abundant because they can come from amniotic fluid, for example. They're more abundant, so they're less costly. So for a fraction of what it costs to go to Panama, you can get that treatment here in the U.S. And it's a myth. You don't have to leave the States. It's not illegal to do those things here, but we cannot make those marketing claims. So we're very careful and compliant in that way. And that's why I've said it like 3 or 4 times here. So the exosomes are really the business end of stem cells. So I'm a big believer in let's go right to the business end. Stem cells also carry someone else's DNA. Not that we see that as a problem, but in the post-COVID vaccination area with messing with our genome or our genes, I don't like that concept. We also know that stem cells don't last in the body very long. So we go right to the exosomes, just cutting out the middlemen, becoming more efficient with what we do.
You brought up a good point too, is not too long ago, or very recently actually, donating blood has become a concern because of those who were vaccinated, COVID vaccines, that the blood isn't void of that. So you could be getting, just like with a stem cell, you could be getting the byproduct of what everybody's talking about now about COVID, COVID vaccine. So someone has to be really concerned about that. So that's why, going embryonic.
We're seeing all kinds of issues downstream now. We're learning about them. And we like to remove that variable where we can.
Yeah.
How do you remove it? I mean, as a patient, can they ask? I mean, how do you remove that?
I only acquire biologics from non-COVID vaccinated donor sources. So now someone recently asked this, and it's a brilliant question. What if the father was vaccinated? And I don't have the answer necessarily. Like, does it get carried in sperm? We know that the egg is the cell and the sperm is sort of the extra, right? You get the mitochondria from the mother. You don't get them in the sperm. You just get genomes. So, but if that genome is affected, that half of the genome anyway, the chromosomes that come from the sperm, does that affect? We don't know.
Interesting.
And is that easy to find out? I mean, if you're a patient, you want stem cells and you ask your doctor, are you sure? Or is that something that's easily found out if it's from a non-vaccinated?
Well, if your doctor can't answer, then no. If
you ask
doctor. Me, I'm only acquiring I buy the biologics, and we utilize them. I only acquire from labs that source from non-COVID vaccinated mother pools.
Wow. Yeah, that's awesome.
I love that he keeps saying that because it's
so important.
Something we stand behind. Really, that's great.
Yeah,
thank you.
So important. Let's talk peptides. Since you've mentioned it a couple of times, that's just becoming, especially, and you also mentioned that's become a buzzword on the internet. And the fact that we're talking about it now, my phone is in the other room, and I'll probably have 9 million peptide stuff on my feed in 20 minutes. Yeah. But so people get, well, I got my peptides from this company. I got it from Genova. I got it from this company. I got it from Regenerative. And I'm like, well, peptides can be very fragile, and compounding pharmacies may say, just like a vitamin C is a vitamin C is a vitamin C. Can you break down peptides and how to find quality and when to use them?
Wow. We'll need a few hours for that, but let me try to. Peptides are small proteins that have therapeutic benefit. we're using a lot of them. We even stack them with some of the regenerative procedures we do. I'm currently on multiple peptides. I experiment with myself first. We source peptides from different, there are two different types of labs. They're called research-only labs, and then there are compounding pharmacies. You'll pay more to compounding pharmacy, but we only source from research or compounding or send our patients to go shop there online if they have third-party testing showing the purity 99% or better and have done third-party contaminant testing. We don't want anything in there. Almost all of the raw ingredients for peptides come from China. Now you can buy on Temu or Alibaba a bunch of peptides for very little, but they come with no testing you can verify. They may come with a testing sheet, but you got to trust what you're getting is tested. Here in America, to import those, the suppliers have to test them. So we would only buy from a third-party tested source who's only using the good stuff. So there are different sources online. Just vet them, make sure they share that transparently. The compounding pharmacies have to do that, and that's called pharmaceutical grade. But some of these research use places do the testing to serve you with pharmaceutical grade, but they're not a pharmacy, so they have to put research use on the label. I use some research use on myself. So where, and then you said where or how do we use them or when? It just depends on the patient. When they're ready, when everything's tuned up and ready to go, depending on their goals. Are you looking for energy? Do we need to do some mitochondrial repair? Is it you need to heal from something? You want to have more rapid healing? Do we need a Wolverine protocol? You're looking for skin and cosmetic health. Maybe you need some copper peptides. You're looking to put on muscle. There are some that help you release growth hormone for that purpose. And then, of course, the most studied peptides are the GLPs, a little weight loss, slow inflammation. I've been on a GLP now for 4 years, lost some weight at the beginning, and now I just a low dose to suppress inflammation because the long-term research shows reduced incidence of cancer, dementia, heart disease, other issues from suppressing the inflammatory burden our environment causes.
Yeah.
He's the
I
strong
hope David
silent type.
No, he is a strong. Yeah, he has a puppy.
Yeah, and I hope David cuts this out, but I put you on mute because he's got a squeaky toy in his mouth. Anyway, I just recently read that in, of course, Silicon Valley, they have peptide raves, and it's exactly what you think. They bring in like a pharmacist or a physician, a nurse practitioner or something, and they inject peptides, a variety of them, to the participants that are dancing around like crazy people. But the takeaway from the article that was in New York Times was fascinating, actually, because it said that they buy bulk from China. I know what you're thinking, but the brilliant part was then they get the product and they send it to an independent lab to get testing and assays that determine its quality. And
okay, good.
That I thought was a pretty cool idea. I mean, not the rave part, but the testing part.
Welcome to California, where we do things fun.
Yeah, right. So anyway, so I appreciate you sharing your thoughts about peptides, because it is becoming something extremely popular. But I also am very cautious because of the fact that, remember how Botox, and even now, Botox was, used in certain circumstances, and now it's like they have Botox parties. So I'm just wondering, at what point the peptides, even though I think they're a little more, useful in many other areas, is that, could that happen as well?
Well,
is it a fad?
The vast majority of peptides are naturally occurring in our body, and just like our stem cells don't work as well when we're older, neither we're not making the right amount or able to make enough peptides. So it's botulinum toxin, Botox, we don't make.
Right.
So, as a friend of mine said, she has to drink red wine on the daily because her body doesn't make enough on its own.
Very good.
I'm going to use that.
And very
that's
true.
Hilarious.
Yeah. Oh, that's great. That's great.
You got these, like you said, you got these peptides. And I think the average person, even some of the doctors get confused because it's like, well, we got regenerative medicine, we got peptides. And I guess it's trying to find the practitioner. I would be so nervous about these parties because it's like, even with microdosing, it's like, it can go bad, and you need somebody that can actually knows what to do, knowing when to use what and how to use it. Is that correct?
Yeah, I mean, you want some guidance. Funny thing is, I do hot sauna for my biohacking. I like to sit in the hot sauna for 20 minutes, and I do it at the gym. And there are these younger guys in there, and they're all talking peptides, and they do it all themselves. And I try to get in their conversation, but they don't want to hear from the old guy. So it's very democratized, and people are out there doing things, and you can screw up. So it's nice to have some guidance. Most of my patients don't live here in Las Vegas, where I'm based. I do a lot of telehealth, which circles back to, not being able to do my physical exam. But we do a lot of guidance of peptides, making sure people are okay. They have a resource. It's good to have a peptide coach or doc or somebody to do that.
So going back to like healing and longevity, and how would you typically measure the changes in someone? Is it lab work? Is it just
asking so body composition is one. Hormone status is another. Biological age test is one, where you actually look at the cellular markers of aging. Could be DNA methylation, telomere length, a few other, glycosylation of antibodies in the system. We also do, inflammatory markers. We might do, pulmonary function tests. We could do grip testing. There's so many measures. And that's kind of how we start when we measure before and afters. HRV, heart rate variability, is another. If you have any health tech, Apple Watch or Oura Ring or Whoop Band or Garmin, you can check your heart rate variability. It's a very sensitive marker, and we want to improve that. That's a great marker.
Very good. Very good. Let's see. Terry, you want to go into rapid fire?
Oh, I would love to hear the rapid fire from this guy.
Well, aside from the overwhelming amount of spot on information, we love this part of the show. It's the rapid fire questions. We got 5 of them for you that may or may not have anything to do with what your specialty is, but it's all about you, and some of your answers can be as concise and brief as possible. Only if you're ready. Are you ready, Dr. Jeff?
As they used to say on Laugh-In, sock it to me.
Oh my gosh.
My God. Yeah,
oh my gosh. I haven't heard that. I just got
we're all in our 60s, and it's finally somebody that we know that. I love that.
That was fantastic.
Artie Shaw, right there.
Yes.
Yes.
How great.
I'm a man.
Yeah. All right. I almost don't even want to go into this now. That was fantastic. All right. Question number 1. What is one spine myth you wish you could delete from the internet forever?
Oh gosh, there's so many. Here's one. People come in and say, my spinal cord is compressed from my L4-5 disc. People, there is no spinal cord below L1-2.
Love that.
Oh, I can take this little segment right here. Yeah.
To all the emergency room doctors out there who are ordering lumbar MRIs for myelopathy, which is spinal cord dysfunction, check your anatomy class. It's been a minute.
Oh my gosh. That one answer I may play over and over again for patients. Yes. Thank you for that. Question number 2. You went from a small town roots and early research energy becoming the, as Dr. Terry put it, the stem cell whisperer. What's the most Ohio kid part of you that never left?
It'd be the Ohio State Buckeye football. That comes in my genes for generations, even though I did not attend the Ohio State University. So I'm still a Buckeye fan. That comes with growing up there.
Go Buckeyes. All right. Question number 3. If you had to pick one, what's more you, a precision optimization or intuition, instinct, give us a kind of a real example from your own daily routine that would describe how you do things.
I have really tried to focus on movement. So muscle is longevity. Muscle is your longevity organ. If you using your muscles with weight-bearing exercise, you will build muscle mass. Muscle mass is correlated with longevity. It also supports bone density. It's one of the recipes for building bone is exercise, and bone mass is also correlated with longevity. So if you want to live long, your body serves its ability to move. And if you're not moving, if you spend a lot of time in a desk chair like I do these days, get up and move, and exercise hard. So going for a walk is great, but it's not enough. You got to use those muscles. They release myokines, small healing peptides.
Nice. Oh, this is great. We're hearing this among a lot of our guests that come on that are very influential, and strength training, resistance training, and all that. So thank you for reemphasizing that, especially from your level of understanding. Question number 4, Dr. Jeff. If everything you know about healing, longevity, and the spine had to be distilled into one belief you'd want your kids, your parents, and the next generation of doctors to live by, what would that be?
I think that, I would add in the exercise piece here too, but I think we can eat our way to health. I think food is medicine, and what we avoid is important. So we need to avoid too much sugar, seed oils. We need to eat more of the earth, and that's fruits and vegetables. And if, for meat eaters, good, clean meat source, not necessarily corn raised or fed pesticide laden corn, but wild grass fed. They have more omega-3s, highly anti-inflammatory. It's a longevity supplement. So food is medicine.
Great. Last question. When the white coat is off, the phone is down, and nobody needs fixing, what's the simplest thing that makes you feel most like yourself again?
Oh, that's a hard one. I'm a workaholic. If I'm done with the white coat, even though I don't really own one anymore, I'm working on something. I'm very interested in nerdy reading about AI, and I'm reading all kinds of new papers. Every morning I read new research, what's out there, what's published. So I would say I keep my nose in the books.
All right. On that, you mentioned PubMed goes back to 1965. Where is your go-to place to get your research from?
Yeah, I still use PubMed. I mean, it's a great database. And I will use AI sometimes to help me source articles to read. I don't rely on AI always to interpret them. And I think we're getting better at that. I just came back from a health tech summit up in the Bay Area. And I pitched, an AI LLM that would take into account all that old literature. I think we're missing something there.
Well, I'll tell you, this was a show that was right up our alley. This is something we deal with every day, and with patients all the time that are underinformed or misinformed. So thank you so much, Dr. Jeff. I appreciate you being on the show. Thank you.
My pleasure. I'm phone a friend for you guys anytime. Just let me know what you need.
I love that. Thank you, Jeff, for your time. And we will put all the information to how to find you in your description of the show. So please, people, before you get cut, before you do anything, at least have a consultation with this guy and get another opinion.
Oh, yeah. Big time. Thank you.
Thanks.
Thank you for listening to today's episode of the Crackin Backs Podcast. We hope you enjoyed it. Make sure you follow us on Instagram at Crackin Backs Podcast. Catch new episodes every Monday. See you next time.